Hello?
Hello, Dr. Davar. Welcome. We're just letting a couple more people populate, so we're going to start here in a minute. Okay. Do you hear me okay?
Yes, I can. Is this too distracting or should I change the background? Or?
No, I think you're good.
Okay.
We already have some people in the webinar, so just be aware that everybody can hear you already. Okay, so now that we're live on Facebook and Twitter, I'm going to go ahead and get started. I just wanted to say to our audience, welcome back to From the Clinic to the Living Room. As you know, I'm your host, Melissa Wilson. For those of you that maybe don't know me, I just wanted to reintroduce myself. I'm currently a physician assistant at the University of Pittsburgh at Hillman Cancer Center, and I do run this webinar, From the Clinic to the Living Room with AIM. Tonight, we're going to, talk about, it's actually a special two-part series. So this is part one of a special two-part week where tonight we're going to talk about the basics of the microbiome, specifically the gut microbiota. And then in part two, which is going to be next week, we'll be discussing a little bit more in depth of how you can actually improve your gut microbiome and why that's more, relevant in melanoma and kind of what we can do to enhance that. So that'll be next week. But tonight we're going to just learn about the gut microbiome and talk a little bit more in depth. So as you all know, or hopefully the reason that you're joining this webinar is that research has already shown that microorganisms in the gut can help and can impact the effectiveness of immunotherapy, and especially in patients with cancers. And even though microbial therapies are pretty new in the early stages of development, there's actually been research that dates back, as far as I've been reading, like all the way back to 2012. So maybe even before that. So this is not something that's a new concept, but things have gotten honed in a lot more in the last few years. And in fact, it's shown that changing the gut microbiome can actually improve outcomes in patients that are getting therapy, including immune checkpoint inhibitors, which, as you know, in melanoma are widely used both in stage 2, 3, and 4 patients. So I'm really excited about this topic. I know we did a little bit about this during COVID, but we have an expert now to talk about it with you. So our guest tonight is Dr. Diwakar Davar. I have the pleasure of working with him in clinic, but he's associate professor of medicine and the clinical director of the melanoma and skin cancer program at the University of Pittsburgh for Hillman. He joins us today to clarify some facts and some misconceptions about the gut microbiome, and especially how it mediates the effects of immunotherapy. So Dr. Davar, thank you so much for joining me after clinic hours today.
Thank you for having me.
Of course. So I guess where I kind of want to start is that the gut microbiome, especially in the last couple of years, not only for melanoma, but in the news in terms of immunogenic health and overall health and the gut mind continuum, it's gotten a lot of interest over the last couple of years. You've done a ton of fundamental work here. You've had some of the first in human studies for this concept in melanoma. So I guess where I want to start is I would like you to briefly summarize what the microbiome very literally is, so that we all are on the same page.
Sure. So, firstly, thank you for having me. And I just wanted to clarify with everybody on the program that I'm very glad to be here. Actually, Melissa predates me in the melanoma program. So really, the clinical director of the melanoma and skin cancer program at the University of Pittsburgh is not me. It's actually not even Dr. Kirkwood. It's actually Melissa. So she's literally the person who spent the most amount of time there. It's also very interesting because she actually is. She didn't mention this, but she's actually the person who treated the very first patient in the very first clinical trial that, and we of course can't mention who that person is, but she actually treated the very first patient in the very first clinical trial of gut microbiome modulation in cancer melanoma. So what is this, right? The human microbiome, we can start with that. The human microbiome is basically everything, and everything means bacteria, archaea, fungi, and viruses. So bacteria, archaea, fungi, and viruses, and that's like a little pop quiz for the people who have, 10-year-olds, that live in all the mucosal surfaces of the human body. That includes the gut, it includes the skin, it includes the genitourinary system, as well as the oral cavity. Now, the majority of the human microbiome happens to reside in the gut. And the gut microbiota, also known as the gut microbiome or gut flora, these are all synonyms, refers to the collective total of the microorganisms, that is the bacteria, archaea, fungi, and viruses that live in the digestive tracts of animals, including humans. And so when we consider the human gut microbiome, that's really what we mean. We're talking about all these different things that live in our digestive tracts, from the literally from the mouth on down. The gut is really that long. The stomach tends to be sterile, so the vast majority of microorganisms tend to be in the small bowel and the large bowel, and mostly in the large bowel. And the term for this is, as we said, gut microbiome. And the gastrointestinal metagenome is basically the aggregate of all these genes. So people may have heard that you're actually more non-human than human, and that kind of where that comes from is that the human metagenome actually is, when you consider all these microbiota, 70% of our sort of total genomic material is actually non-human, and it mostly comes from these bacteria, viruses, fungi, and whatnot.
So thank God for that, because they seem to make up most of our cells here. So
yes,
I guess the biggest thing that I think like people have a hard time conceptualizing is like when you hear the statistic of like the majority of our immune system is housed in our gut, like how do you imagine that? Like what is the function of the gut microbiome? Because, and I guess like from here on it, let's call this the gut microbiota, because that's basically the living things that live in our gut. But like, why, like, what is the function? Obviously we need them, they need us, but how does this work?
Sure. Yeah. So we can start by talking about, some simple basic terminology, right? So the gut, we talked about what is the gut microbiome. Now, when you talk about the communities, we are largely talking about the bacterial communities. So I said there were four major things, fungi, archaea, viruses. We, truth be told, don't know very much about what those three things do. We know a lot about some of what the bacteria does, and even then it's not perfect, but most of our knowledge comes from the bacteria. So these gastrointestinal microbial communities, bacterial communities, largely comprise four major phyla. You can think of these as, say, races or ethnicities, but they're really like four big groups, and these are Bacteroidetes, Firmicutes, Proteobacteria, and Actinobacteria. But the point being that if you go to Giant Eagle, or if you go to, GNC and you buy something, what you buy, in many ways, like for example, lactobacillus, people buy, like for example, a yogurt thing that contains lactobacillus. That lactobacillus comes from the phylum Firmicutes. So almost everything that you've heard of belongs to one of these four major phyla: Bacteroidetes, Firmicutes, Proteobacteria, and Actinobacteria. And the relative proportion of these taxa vary dramatically between, firstly, people. So the two people on this call and many other people who are listening in have very different bacteria. But even within a given individual, that varies dramatically over the course of that person's life. And the effect of this, is well illustrated by some simple models of disease. So one example is, most people have heard of the term C. diff or C. difficile colitis. So C. diff or Clostridium difficile colitis is actually a very common organism. It causes a fairly common infection most of us have heard of, called C. diff colitis. And it's actually one of the most common hospital-associated infections in the United States. C. diff colitis is 250,000 hospital-associated infections, 13,000 deaths annually, according to the CDC, and it's kind of sort of expensive. So each infection costs between 10 grand to 30 grand to treat. So if you assume there are 250,000 annual infections and $30,000 per infection, that is a $7.5 billion industry, right? And that's just how much money it costs. And as it turns out, C. diff is a commensal. It's a commensal. You and I have it. And it's present at low levels in most people, starting from the time that person is a neonate.
Right.
And even though it's a fairly common, not the commonest, but a fairly common organism, it does not lead to most active infections in most people. What it needs is a perturbation, meaning that as the neonate grows, is exposed to the environment, other microbial species are introduced, they become dominant species, they outgrow C. diff, and C. diff exists in a low-level dormant state. And then what happens, and almost everybody's heard of C. diff, and they think of C. diff and they think of antibiotics, is what happens is the antibiotic happens. That antibiotic perturbs native gut flora. It dramatically alters the host microbial equilibrium, resulting in overgrowth of the C. diff species. So the idea is that, just using this as an example, the gut microbiome plays a critical role in human physiology. It helps, for example, prevent, for example, these super infections. It helps maintain pathogen resistance. It maintains the intestinal epithelium. It helps us metabolize certain dietary compounds and pharmaceutical compounds, helps us, for example, produce vitamin K, controls immune function. And in so doing, it helps us maintain health. So it's actually not particularly surprising that it actually plays a role in both the different aspects of cancer, from the development of cancer, the treatment of cancer, and then potentially also cancer immunotherapy.
Yeah, it's a fascinating to me, and the more reading that I did, not only for this webinar, but in the prior webinars where I kind of explained a little about the microbiome, the bacteria in your gut can actually hurt you, but it can actually help you as well. And I know that there's been a lot of, published literature relating to, even anxiety and depression being improved with a healthier gut microbiome. And it's interesting how much inflammation those bacteria that are not as favorable to the normal flora can actually contribute to diseases and disorders, and in our setting, obviously, how it affects immunotherapy. I think it's interesting, and it's become very, very interesting in the people that we've talked to, how chronically taking antibiotics, chronically taking proton pump inhibitors really affect the gut microbiome and also responses to immunotherapy. So I think, how does, in your realm and our realm treating patients, how does this gut microbiome affect specifically immunotherapy and cancer?
So we can break that question down into sort of three things and say that, are people surprised that the gut microbiome is implicated in cancer, and how might it be implicated in cancer treatment and immunotherapy? So the first thing is that, right, the idea that what you have in your gut can cause cancer kind of sounds surprising, but actually should not be, right? So firstly, the best evidence we have is actually H. pylori. So H. pylori, microorganism, normally lives, actually most people don't have it, but it's a spirochete. It's a spiral-shaped organism that lives in the mucus layer of the human stomach. Most bacteria cannot survive the stomach's acidic environment, but H. pylori produces a native antacid that actually neutralizes the surrounding pH and allows it to survive there. And this local neutralization helps H. pylori survive. Chronic H. pylori infection is associated with gastric cancer, and also very specifically gastric lymphomas, what are known as mucosal associated lymphoid tissue lymphomas or maltomas. And this entire thing was figured out by a group, two guys, one very famous Australian, Barry Marshall, and Robert Warren, and they won the Nobel Prize in 2005. And the point is that we've known about this, meaning we've known that a bacteria can cause cancer for since the 1970s and 80s when they did their work, and they won the Nobel Prize in 2005. And therefore, we've known that eradicating this particular bacteria can actually prevent cancers, which is kind of sort of a good thing. But outside of H. pylori, right, the idea that there is the link between bacteria and cancer started happening really in the 2010s. And so what happened was there was again, recall, the first checkpoint inhibitor to treat melanoma was, sort of CTLA-4, and that was FDA approved in the early part of the 2010s to 2012. PD-1 was really 2015, but in 2010, 2012, there was these sort of couple of papers that came out that suggested that the composition of the gut bacteria could affect the effects of immunogenic chemotherapy, what is known as immunogenic chemotherapy, but in breast cancer is really sort of Taxol. And around about the same time, people were studying the composition of the gut bacteria in human cancer patients receiving checkpoint inhibitors, but back then it was CTLA-4. So in 2015, there were these two sort of seminal papers, one by Laurence Ziverger from IGR in Paris, and the other from Tom Gajewski, well-known melanoma immunologist at the University of Chicago. And these two papers sort of basically implicated the gut microbiome of patients receiving CTLA-4 therapy in the effect of the efficacy of CTLA-4 blockade. And these papers were very prominent papers. They were published in Science. Since then, there have been a deluge of papers. Many groups, we have to keep in mind that a lot of this data emerged in melanoma, and therefore melanoma investigators are credited for this. So prominent investigators such as Jen Wago, people from University of Chicago, such as Tom Gajewski, certainly investigators at the University of Pittsburgh, we helped as well, and also the group at IGR. So Gustave Roussy with Laurence and Bertrand Routy demonstrated that these host-associated microbial biomarkers were associated with the efficacy of immune checkpoint blockade, but very interestingly, also side effects of immune checkpoint blockade. So you really think about the composition of the gut microbiome as being both a predictive and a prognostic biomarker, but also different metagenomic or microbial signatures appear to be associated with side effects in patients who received checkpoint inhibitor therapy. And really, this is now sort of well accepted and is really part of the work that we're trying to think about as we go forward.
Yeah, and I mean, as you all know, and all our viewers know, I mean, immune checkpoint blockade has been used from the anti-CTLA-4, now with anti-PD-1. It's being utilized in adjuvant setting in stage 2 and stage 3, obviously stage 4 for many, many years. You've already kind of touched on how this is important in melanoma, but like what I want to see moving forward is like how does this actually applicable? Are there trials?
Yeah.
Are there things that we can do?
Sure. So firstly, that's a great question, right? And so if you think about it from a melanoma patient's perspective, if you're a melanoma patient, right, one would hope that particularly we have to be very grateful to AIM for actually producing the literature, actually I think written to a large part by people like Melissa, that have actually educated patients in patient-centric language about the treatment options, right? And so one thing that almost every melanoma patient knows is, what is my BRAF status? So if you think about it, right, all of these things, BRAF, TMB, tumor mutation burden, and if you've heard of it, interferon gamma gene expression signature, all of these features that are important for your treatment and are used by your physicians and your care providers to make treatment decisions. These are all tumor-associated features, right? So everything that we know that we use to try to decide, how does something work or how does something not work, comes from the tumor. But as it turns out, you cannot think of the tumor in isolation, right? The tumor happens in a human, and as it turns out, if that human is 70% non-human because of the microbes, well, what about those factors? How are those factors assessed as we think about the gut as we think about the efficacy of immune therapy, right? So where what I try to impart to people is that the way you want to think about this is, as we focus on biomarkers of response to checkpoint inhibitor therapy, and we really think about the tumor-associated features such as BRAF mutation status, tumor mutation burden, interferon gamma gene expression score, we also need to start thinking about host-associated factors. So increasingly, there's a body of literature that talks about HLA haplotype. Certainly in melanoma, we have the first drug that is approved based on the HLA haplotype, that is A20201 in the context of tebentafusp for the treatment of choroidal or uveal melanoma. But outside of that, the host gut microbiome is very important, we think, in determining both the response to therapy, the development of side effects to therapy. And sort of the key takeaway from that is two things. One, if we assume that this is true for the sake, even if you don't believe this, let's just say for the sake of argument, there's sort of three kind of takeaway things that you want to think about. The first thing is that if the microbes are important, it kind of sounds like taking something that might hurt them is bad, right? And so
Right.
antibiotics appear to be bad. Now, you don't have to believe in this to believe that antibiotics are bad, because there's enough data out there to say that antibiotics, or rather over-exuberant use of systemic antibiotics for undetermined or indefinite durations, may be a bad idea. So that's
Right.
kind of like one thing. We don't even want our animals that we consume taking antibiotics. Why are we so keen on giving them to ourselves?
Right.
The second thing is that if you are mostly bugs and your bugs are what they eat, well, it stands to reason that you are what they eat. And so therefore, it's very important. Nutrition is a very important part of what we think is going to be, firstly, shaping the response to therapy. And there's some very sort of key investigators who are doing some work in that space. I want to call out the work of Jen Wago and Jennifer McQuaid at MD Anderson, the University of Texas, who have shown, that the intake of the response to checkpoint inhibitor therapy, or the likelihood of probability of responding to checkpoint inhibitor therapy, is to some extent, determined by how much fiber you take. And so, again, this is not also particularly rocket science. I mean, the idea is that fiber is good, right? I mean, your
Right.
grandma tells you that fiber is good. Grandma eats prunes. So if grandma is eating prunes, why aren't we taking more fiber? The average amount of
Sure.
fiber, right, that the American Gut Association recommends that you take is approximately 15 to 20 grams. How much does the average American consume? 5. So how much
I
do
was
they
gonna say
recommend?
4.
15.
So yeah.
And the average person is taking 5. So one, you know, um try to minimize use of antibiotics. 2, if you are what you eat and your gut microbiome is shaped by what you eat, think a little bit about healthy eating. And, there's some increasing data about both the use of high fiber, but also the use of a Mediterranean diet, work from Tim Wiersma, as well as Tim Spector and Vince Wiersma at London and Groningen, respectively, in a paper published in JAMA Oncology, showed that the Mediterranean diet may be favorably associated. And finally, this is something that we can intervene upon. So there are sort of 2 areas. Firstly, there have been attempts to try to treat checkpoint inhibitor side effects with microbial modulation. So the work that's going on here in the University of Pittsburgh, and also work that's going on in MD Anderson's pivotal trials that are being done to try to treat side effects by changing the gut microbiome, and also people trying to treat um, cancer that is not responding to immune therapy by modulating the gut microbiome.
Yeah. So you got into a little bit of what we can do to change our microbiome, and we're going to talk about that next week. But I think what I want to kind of end our this week webinar with is, you touched on, the failure rates in immunotherapy. Even though immunotherapy has opened so much for melanoma, response rates are so much higher than they were when, the dinosaur of me started in 2005 with Dr. Kirkwood. We know that, and you said the intestinal microbiome can absolutely affect response rates. So, you touched on this briefly. In 2021, there were 2 trials in anti-PD-1 and PD-1 advanced melanoma, showing that very literally you can change the response by changing the gut microbiome. Your work with some of our other colleagues here at the University of Pittsburgh was one of those studies. The other one was Dr. Borsi, I think that's how you say their name, at Sheba. I just want you to very briefly talk about the studies and how they're similar and different, just so that our audience understands the data that came from these.
Sure. So, firstly, I was actually on a phone, a ASCO podcast with Ben, and Ben's actually in Sheba in Israel. And as we all know, the events of the last couple of days have been very tragic, and so we are all thinking about him. He is safe, thankfully, and actually he's still very interested in making sure that the patients go on clinical trials, which is really quite remarkable given everything that's happening there. But the short answer is that in 2021 there were 2 pivotal results, but it was really the work of several years of sort of that led up to that, right? So in 2015, there were these papers that came out that suggested that CTLA-4 might have an effect, might be affected by, the composition of the gut microbiome. And then in the 2018 papers that were published that looked at the role of the gut microbiome composition that implicated certain dysbiotic organisms in the non-responsive checkpoint inhibitor therapy, work that was published again at University of Chicago by Tom Gajewski, IGR by Laurence, but also MD Anderson by Dr. Wago. What most of these papers concurrently did was they also looked at avatar mice that were re-inoculated with stool from non-responders in whom the tumors appear to grow more quickly, and also responder-associated derived stool in which the tumors appear to grow more slowly. And so this suggested, very preliminarily that, you can change the gut microbiome. Firstly, you could change it by using a fecal transplant, and two, you can change it with the goal of actually causing cancer regression. And so what two groups did completely independently, it's not like Ben and I were actually talking to each other, but two groups did this completely independently, is that in Israel, Ben working with Gail Markel, and designed a clinical trial in which they took the stool of responders and essentially inoculated non-responders with those tools. The donors were essentially durable melanoma responders, complete responders, so CRs. There were a total of 2 donors that they utilized, and they treated about 10 patients, and about 3 of their patients had these very nice cancer regressions, partial or complete responses. At the University of Pittsburgh, we had a total of 8 donors, and we included both durable complete responders as well as durable partial responders. And we gave patients who had primary refractory melanoma. These are patients who have never responded to cancer immunotherapy before this. We gave them a single fecal transplant and continued pembrolizumab. And what we found was that out of the people that were treated, out of the 15 people that were treated, 3 people had complete or near complete responses, and 3 people had additional long-term stable disease that lasted more than a year. And what we were able to demonstrate in both studies collectively was some of what we now think are the key hallmarks of successful microbial experiments in humans. And the first, interestingly enough, in the paper that was published in Science, showed that engraftment appears to be important. So if you can think of what engraftment is basically the transferred microorganisms taking root. Now, again, if you don't know anything about melanoma and you happen to be listening, and for whatever reason you know a little bit about hematological malignancies in stem cell transplants, it's not surprising that in stem cell transplants and anybody receiving an allogeneic stem cell transplant, one of the key marker of success is basically what is termed the engraftment rate, right? What is termed the likelihood of seeing your donor's bone marrow replacing yours. You want to see what the chimerism statistic is. And so actually that is very similar when it comes to a transplant. If the transplant literally does not take as defined by engraftment statistics that we've now since come up with and defined, that transplant is not going to be successful. Now, people cannot engraft for many reasons. There are many ways, many things that you can do to facilitate engraftment, such as literally creating space by either using some kind of bowel lavage, or some people use gut selective antibiotics, but engraftment is key. So that was one of the key themes that came out of the early experiments. The second was proof of concept. This actually does work. It's not going to work in everybody. Right. It's not going to be something that cures all cancer. It's probably not different. It's going to be different from person to person. It's going to be different patients are going to benefit differently. But in the small select group of patients, just changing your gut microbiome appears to be enough. And then the third sort of observation, which I think is the mechanistic aspect of this, is that what we think we're doing is mechanistically, we're trying to figure out, and we think we've sort of come to the idea as to how this might work. So both papers in Science demonstrated that the effect of the transplant was to produce more immune cells within the tumor. But the paper that we published also demonstrated that response to transplant was associated with a reduction in intratumoral myeloid cells. And this was work done in Hassan, who's the corresponding author on the paper, and my close collaborator, Hassan Zarois, and he's also the co-director of the program. And occasionally, works with Melissa in the context of her practice as well. And what Hassan's group was able to demonstrate was that there was a reduction in the CXCL8 or islate producing myeloid cells. And in a subsequent publication in Nature Medicine, we were able to demonstrate that non-responding patients to checkpoint inhibitor therapy had high amounts of a myeloid tone. And this central idea appears to be that people are predisposed to respond to immune therapy,
Yeah.
except if you have something going against you. And the thing that
Right.
might be going against you is nothing that you did, but certain bacteria that you have that promote, for whatever reason, a high systemic inflammatory myeloid tone. And that myeloid tone, if you happen to develop cancer and happen to need a systemic immune checkpoint inhibitor, can potentially be detrimental because it can promote the sustenance of a myeloid program of intratumoral myeloid cells, CXCL8 producing myeloid cells, that are well known to prevent the effective function of CD8 T cells. And
Okay.
so sort of the key the result of the proof of concept experiments was to highlight, firstly, the proof of concept. This kind of sort of appears to work, so it may be something worth studying in both this cancer and other cancers. And two, figuring out how it works, potentially via the myeloid axis, is important, because we've been trying to drug myeloid cells for a very, very, very long time in melanoma. For example, people might be acquainted with the idea of lenvatinib and how the LEAP-004 study was, positive in the refractory setting, but in the naive setting, LEAP-001 was negative. Pembro-lenva did not appear to improve the outcomes compared to pembrolizumab alone. But what does lenvatinib do? Lenvatinib appears to actually, one mechanism of lenvatinib appears to be by reducing the intratumoral myeloid cells. So people have been thinking about how to target myeloid for a very, very, very long time. Now, I'm not saying that changing your gut microbiome is the key to it. I think it's certainly one part of it, but that appears to be the mechanistic link. And then finally, these proof of concept studies also clarified one key biomarker, which is how do you measure that anything that you do is actually working? Well, beyond looking at cancer regression, what you need to look for is the pharmacodynamic effect of the drug in question. And the drug, and it really is a drug, the microbial transplant, the effect of that can be measured using metagenomic engraftment, which is no different conceptually than bone marrow engraftment.
Right. So that being said, and I don't want to try to take too much, push us too far over, but I guess one of my questions then is, like, where do we go from here? Like, where do we go in the science from here?
Okay. So, firstly, we have to thank the melanoma community, because actually at the MRA meeting, the Melanoma Research Alliance meeting in February this year, there actually was the first time, actually the first time it happened, there was the first time in which a microbiome session was convened. So there were literally 30 people who got in a room, and all we did was we talked about microbes. Now, it's not like we literally talked about poop, and it's not like there were poop emojis everywhere, but literally we sat down and we talked about the role of the gut microbiome in cancer, particularly in melanoma, how this might be studied. And all of these efforts resulted in a white paper that will shortly be published in Cancer Cell. It's not exactly, bedtime reading, it's kind of dense, but the point is that in that white paper, we sort of laid out some ideas for the field to think about. And some of those ideas, just to give people context as to what the way we are thinking about this, is that some of the very important aspects that will need to be studied going forward include further mechanistic work, both in humans, but also in the appropriate model systems to tease out further the mechanistic understanding of how the microbes might be working, and to find new biomarkers of what constitutes successful engraftment, also what constitutes favorable and unfavorable gut microbiome. Laurence has come up with the idea of GEMS or GOMS, a gut oncogenic microbial signature. And it's a very unwieldy acronym, but essentially what it is this idea that there's a key biomarker that potentially can be used to sort of figure out who has sort of a good and who has a bad gut microbiome. So that's kind of like one theme. The second theme are areas of interest, and we can talk, and some of this we'll be discussing next week, but how can you intervene, and which are high priority areas to intervene upon? Now, it stands to reason that trying to study the role of the gut microbiome in a patient with say glioblastoma may not necessarily be high yield because glioblastoma is a low tumor mutation burden tumor, a tumor in which checkpoint inhibitors do not have a high incidence of success, for example. But in melanoma, which is the topic of conversation, this is certainly of interest. But when we think about which areas in melanoma we want to study, if we're thinking of the role of the gut microbiome, we might want to study it more carefully in tumors like conventional cutaneous melanoma, as opposed to, say, choroidal melanoma or acral melanoma, where the efficacy of checkpoint inhibitor, or mucosal, where the activity of checkpoint inhibitor is lower. But where these other tumor types might be important is for other kinds of microbial studies, such as the role of the intratumoral microbiome, where it appears that certain cancers appear to be colonized with bacteria, and that colonization may actually affect the development, the growth, the sustenance of the cancer, and potentially resistance to treatment. And it may be that these other tumor types are actually a good model to study that in, because they arise in mucosal surfaces and they're actually fairly resistant to checkpoint inhibitor therapy conventionally. So uveal, choroidal, acral, lentiginous, and certainly mucosal. And then we've also, in that white paper, talked about some key areas in how we can think about interventions. So beyond whole-scale fecal transplantation, there have been early attempts made to try to look at sort of single microbes to try to change the gut microbiome, consortia, which are groups of different bugs that try to change the consortium. And we're not quite there yet, because some of the early consortia studies, and there have been three that are well known. Matt, there was a study by a company known as Vedanta VE800. This has not been publicly read out yet. Two other studies with a company known as Series, SER401. This has been publicly reported by the MD Anderson Group in combination with Nivo versus Nivo monotherapy. The combination was not more successful than Nivo monotherapy. So it appears that this consortia does not appear to be that effective, but we don't know whether or not the use of concomitant antibiotics may have harmed the microbial consortium. And then there was a third study that was also looking at a microbial intervention by a Canadian company, and that study was a single-arm study. So the data is, promising, but we need further pieces of information. And so, are we ready to pick bugs? We don't quite know. We're still kind of at that stage. And if we don't know which bugs to pick, it appears that some of the early trials that appear to be going forward appear to be whole-scale fecal transplantation. So, for example, recently there was a paper in Nature Medicine by my colleague Bertrand Routy and John Lanahan. They demonstrated that PD-1 monotherapy plus a fecal microbiome transplantation from a healthy donor appear to produce response rates of approximately 60-something%. So that 2/3 of patients appear to respond to PD-1 monotherapy. Again, non-randomized phase 2 study in the PD-1 naive setting. And so we don't know, right? Is that because of PD-1 in a select patient population? Or, was the gut microbiome adding that much more? We just don't know. Suffice to say that we have in that white paper outlined a couple of ways forward, including the use of further fecal transplantation trials to try to home in on areas of importance to study, as well as demonstrate proof of concept that can be further used to define consortia that may be ultimately the product of academic industrial collaborations to define a particular drug.
More to come, but everybody is super excited. I know that there's a lot of folks that are really excited about next week when we tell them exactly how to, well, not exactly, but some ideas of how they can make their gut microbiome a little more healthy. We're just going to take one question tonight, and then we got to wrap this up. But Keith Tolley had asked if antibiotic use is medically necessary for a melanoma prior to immunotherapy treatment starting. Is there a period of time for the antibiotic to be, quote, washed out of the body before the immunotherapy should start to help improve the efficacy, or is this still unknown?
Sure. So that's a very, very good question. And I would take that question in sort of two parts. The first question is, if antibiotic therapy is medically necessary, it is necessary. Like you don't want to have a rip-roaring lung abscess and try to go on immunotherapy because, if you die of the lung abscess, you're never going to give yourself a chance, right? So if you need the antibiotics, get it. But one of the key things that you want to think about is the duration of antibiotics, right? So I recall when I was an intern and my resident would ask me, what was the duration of antibiotics? And the short answer was, for some strange reason, it's almost always an odd number. It's 3, 5, 7, unless you have a bacterial infection, in which case it's 2 weeks. And everybody knows this, but nobody really knows where this number comes from. Like, why is it that we give somebody an antibiotic for 3 days if you have a UTI, or 5 days of this if you have community acquired pneumonia? I mean, it's kind of surprising that all these numbers just are random odd prime numbers. Like, why isn't
Yeah,
it like 14 days and 1/2 of a day?
right.
So there's the short answer that I would start with is the shortest possible duration,
Yeah.
right? So keep in mind that, firstly, do you really need it, right? Like, so how many times do people like me prescribe antibiotics on the phone for something that we think is a pneumonia, but probably really just is a cough and a tickle? And
Yeah.
so the way to think about that is reducing the amount of indiscriminate antibiotic usage by both reducing antibiotic usage and also reducing unnecessary usage by shortening the course of therapy is helpful. Because again, in the C. diff setting, what is associated with C. diff? Prolonged use of broad spectrum gram-negative killing organisms. Antibiotics is associated with it. So try to use a narrow spectrum antibiotic for the shortest duration possible rationally. So that would be one simple thing. The second thing is, if the antibiotic usage is medically necessary, the immune and it's kept short, typically sort of less than 3 or 4 days, it appears to be that your gut microbiome can actually recover. But let me just give you sort of a context, right? So there was a meta-analysis published that looked at the role of antibiotics in terms of checkpoint inhibitor treated patient survival. Now, again, the limitations are the meta-analysis, so the potentially sources of error, because not all the studies may be similar, but what they were looking at are pooled studies. They were pooling studies in which everybody had looked at antibiotics versus no antibiotics for checkpoint inhibitor treated patients and their survival. And the hazard ratio for antibiotics was 4. Meaning that the probability of responding or having poorer overall survival as a result of antibiotic use was 4 times greater in antibiotic treated patients compared to non-antibiotic treated patients. Now, when we think of what that means, right, let's just think of what PD-1 and CTLA-4 do. PD-1 monotherapy, 35 to 42%. CTLA-4 adds 15%. So if PD-1 gives you 30-something% and CTLA-4 adds 15% to get you to 45%, and relatlimab is like 45% because it adds about 10% to PD-1, antibiotics given for a long period of time can take all of that away.
Yeah,
Right.
that's crazy.
So it's kind of crazy when you think about it, in that we do so much to try to get people, we push them through side effects, we tell them to suck it up, we tell them to not mind the dry mouth and the hypophysitis and to go on the hydrocortisone and all that sort of stuff. But we could very easily undermine all the gains that we have by just giving somebody, an indiscriminate 4-week course of intravenous ceftriaxone or ceftazidime without thinking for an infection that we don't necessarily know it's real. So the point is, shortest possible duration, narrowest possible antibiotic, and for what is rational as opposed to something that's irrational, and try to start the immune therapy soon after that. But if you do it for as little as possible and at the lowest possible dose, you might be able to get away with it.
All right. Well, so I think that kind of teases us into next week. So next week, we're going to dive a little bit more into things like antibiotic use and the types of foods you can eat and things like that. So I hope everyone enjoyed learning about, what the microbiome is, how we can harness it for melanoma. Dr. Davar, you've given us lots of things to think about. I know that we have lots of people registered for next week to kind of talk a little bit more about the intervention. So I really appreciate you joining me tonight. I will see you very soon, I know, but we'll see everybody hopefully back next week to talk a little bit more.